Hello, welcome everybody to our webinar tonight. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands we walk, reside and work upon. We pay our respects to First Nations people and value the continued connection to culture, country, waterways and contributions made to the life of our vast region. This is our last webinar in our fertility series tonight, and the topic is fertility preservation, egg freezing, social and medical. Don't forget, if you have any questions, please type them into the question box, and at the end of the session, we'll endeavour to answer them all. Tonight's session is being recorded, and there will be a copy of the recording uploaded to our education library, which you can find on our website. I will hand over to Dr. Angela Dunford. Angela is a gynecologist who works in Newcastle. She works at John Hunter, but also from private rooms. All right, thank you so much, Angela.
Thank you so much, and thank you very much for having me, and for all of you who've tuned in this evening in your precious after hours time. Thank you very much. Tonight I'm going to give a bit of an overview on fertility preservation with a focus on medical and surgical egg freezing. I'm Ange Dunford, for those of you who don't know me, and I have a special interest in paediatric and adolescent gynecology, as well as gender diverse gynecology and fertility. And I work out of John Hunter Children's Hospital, and Newcastle Fertility Specialists, who are affiliated with Genea Fertility Specialists in Newcastle. So tonight I've put together a bit of an outline, and I hope it covers some interesting material, but also gives you a little bit of a peek behind the curtain at what happens when patients come into a fertility team for discussion, particularly about egg freezing. I'll start this evening with a bit of who, what, when, where, why, covering fertility preservation in general, and then drill down a little bit more on an egg freeze cycle for medical or social reasons. I've divided a few slides into the common questions that I get from both clinicians who are referring in as well as patients. I haven't actually dwelled on the clinic-specific success rates tonight, but I've got a slide to give you a database to direct patients to, or to look at yourself for information about local and Australia-wide fertility teams and their success rates. I am going to spend some time talking about ovarian tissue harvest, because in my adolescent and paediatric role, it's a really important part of my fertility preservation counselling. And so is counselling gender diverse patients before they embark on gender affirming hormonal treatment. All of that I hope to take about 30 to 40 minutes, because after that you'll be sick of the sight and sound of me. But I wanted to leave enough space at the end to make sure that all of you have your needs met. So if you've got questions throughout the course of the talk, things I haven't touched on that you wish I had, or things you wanted a little bit more detail in, please bring them up at the end so we can have some time for some open discussion. So who comes to us for fertility preservation? There are two main groups. The increasing group is the social egg freeze group, where healthy women wish to preserve eggs so that they can have a pregnancy at a later date. And this area is really forming most of my fertility consultations now in private practice. The other group are the medical reasons for fertility preservation. So these are people who are about to embark, especially in cancer treatments with chemotherapy or radiotherapy, that have a high chance of impacting their gonads either immediately or in the short, medium to long term. There are also some medical conditions such as SLE, where they may need high doses of cyclophosphamide or big doses of methotrexate, or patients with thalassemias who need bone marrow transplants. And for bone marrow transplant, there's about an 80% chance that the gonads won't function post-treatment. There are also groups of patients who have a known low ovarian reserve at a young age, or they have an AMH done out of curiosity and discover that it's low. And of course, transgender patients prior to transitioning. And we've also got an increasing group of young women who are learning more about endometriosis and becoming more informed, who've had previous surgeries, who are at a risk of having surgeries on their ovaries down the track. And we know that each time we operate on an ovary for a cystectomy, we do deplete the ovarian reserve. The options that are available are listed here. The two top ones in bold are where I'm going to place most of the focus this evening, but I will briefly touch on embryo and sperm freezing. Testicular biopsy and tissue freeze is something that we hope in the future to be able to utilise for pre-pubertal boys who are about to have treatment that will impact their gonads. But at the moment, it's incredibly specialised. It's very much an experimental treatment, and it's only available under a research banner. The impact of age is something that really we can't get around, and this is probably where our big influx of patients have come from, wanting to explore social egg freezing. And it's to do with the limited fertility window that we have as women that we aren't really able to do anything about. And it's the single most important influence on your chance of pregnancy. We all know that a woman's born with all the eggs she'll ever have in her lifetime, and the quantity definitely drops off over time, but so does the quality, and it accelerates probably from 32 to 35, which is terribly young, really. Once you turn 36, your chance of a natural pregnancy drops from 25% per month when it's at its peak at age 22 down to 15%, and then it drops to about 5% by the time a woman's 40. And that again is due to a combination of the decreased egg number, but also the decreased egg quality. And also that obviously comes along with an increased miscarriage rate, and because of the abnormal chromosomal makeup of those eggs that are remaining. Age is also important when we're talking about IVF cycles. You can see from this graph, and this is talking about take-home baby, not pregnancy rates, but your success drops by 15% in the 2 years from 37 to 39. I think the nicest part of this graph, though, is that people undergoing IVF treatments at the age of 37 still have a 63% chance of taking home a baby. But I think as women become more aware of these facts and more in touch with their fertility, they're asking questions and wanting to explore these options more. And also, I guess, with increased age at first pregnancy, this is going to become even more important. So the process of socially egg freezing really refers to storing eggs in healthy, fertile women who want to have a pregnancy at some point down the track, hoping to optimize their chance of a successful pregnancy at a future date. And it's such an unusual concept coming from a fertility space or an IVF space. It's unusual for us to put patients through the expense and physical procedures that go along with this, hoping that we'll never have to use them. And unfortunately, it hasn't really turned out to be that perfect insurance policy that we would love it to be. And it by no means guarantees a baby later if fertility is delayed. But where previously there were no options, we now have the chance to have a conversation and gain information and use that information to make informed choices that are right for us at that point in our lives. There's pretty good evidence now that up to and including the age of 39, 1 or 2 egg freeze cycles have been shown to be cost effective compared to starting IVF at the age of 40 or above. And again, as with most things in fertility, your best chance of success with good egg numbers and good quality comes from when you embark on this early, but it needs to be balanced with not putting young women through this too early when there's a really high chance that they're not going to need it. So striking the balance is important, ideally at or before the age of 35, but of course we can still do it much later than that. I'll spend some time now walking through the steps of an egg freeze cycle. You can see from this diagram that the first 2 steps, which are the egg freeze cycle, so the stimulation of the ovaries and the egg collection, are exactly the same as what we use for an IVF cycle. We just stop at that point and then go on to vitrification or freezing of the eggs down. An IVF cycle typically takes about 3 weeks from the time of the first injections to the time that we embark on an egg collection. And an egg freeze cycle, depending on which cycle we use, but for the most common cycle, is about 9 to 16 days in total. This picture summarizes really nicely all the steps in one of our standard egg freeze cycle protocols. There's a lot on it, but I like it because it has everything together as I explain it. So this is an antagonist cycle. The antagonist component refers to the medication we use to try and block ovulation. It's an increasingly popular cycle type because it decreases the risks of patients experiencing ovarian hyperstimulation syndrome. So it's really ideally set up for women who aren't having a full IVF cycle but who want to collect eggs and freeze them down. So each month in a natural ovulatory cycle, when we're outside of IVF, the ovaries have a pool of antral follicles that are laying in wait that month to be stimulated by FSH from the brain. FSH recruits the follicles, and usually one of those follicles responds much better to the FSH than the others. It releases estrogen, and then it eventually becomes so solid and robust that it is independent of FSH stimulation. As well as estrogen, it releases inhibitory factors, and that the rest of that pool that was there that month goes through apoptosis, never to be used again. So people do get worried that an IVF egg collection cycle accelerates the use of those precious eggs that they've got over their life, but it doesn't. It just takes advantage of a system that nature perhaps doesn't do quite as well as we do sometimes. So what we do is give a man-made version of FSH via injection every day, and it starts from the first day of the menstrual cycle. After about 5 to 7 days, we measure estrogen levels to determine that follicles have been recruited, and that's when we add in the GnRH antagonist to stop the brain from wanting to ovulate off those developing follicles. So then there's 2 daily injections. We monitor throughout the cycle with a combination of estrogen levels to check the follicle recruitment, as well as a transvaginal ultrasound scan, which helps us look at the size of the follicles and the number of the follicles. Those monitoring procedures are always done very early in the morning so that people's lives can continue while they're cycling through this. You can see from the images of the ultrasound pictures on your screen, the one on the right is the baseline ultrasound scan where you almost have to squint or you'll miss it and try and make out where the little ovary is because it's quite hard to see. The middle one shows an ovary that has begun recruiting those follicles. The ovary is a little bit more distinct. The follicles are more obvious. They're bigger and they're trending towards sort of uniform size. The final picture on the right is an ovary that's ready for triggering an egg collection. It has a good number of good sized follicles that are all uniform, and that's what we tend to see when we do the transvaginal egg collection. When we see that on follicle scanning, that says that it's time for us to trigger. We either do that in this type of cycle with a dose of HCG, or if we think the patient is overstimulated or at risk of OHSS, we can use a GnRH agonist. In our lab, we use Cineral nasal spray, and that stops the HCG from driving the ovarian hyperstimulation and making the patient more unwell. This component is the one that's really time critical. From the time of trigger to egg collection is always 36 hours. So patients, that's the only bit that's a bit inflexible and they need to leave work for that bit. This picture demonstrates an ovary at the top that is going through a natural cycle with one dominant follicle, which will be the follicle that ovulates off. And you compare the difference to the ovary below, which is a stimulated ovary where there are multiple follicles growing in size and becoming big together. So the next step, of course, is collecting the eggs, and that's the main procedure involved in an IVF cycle. In Newcastle, this is conducted via an admission to Lingard Hospital. If you're with Janaea, and then we bring you through to an adjoining medical procedure room at Janaea to do the procedure itself. It's an ultrasound guided procedure where you can see in real time, because we project the images that I can see on ultrasound, where via the vagina a little needle guard is clipped onto the transvaginal ultrasound scan. We insert that needle into the ovary, into each follicle, and the follicular fluid is aspirated up hopefully with an egg. The typical egg collection procedure, you're in and out of that room within half an hour. So it's incredibly quick, really, and that includes all of the steps we use for sedation, placing the drip, nasal prongs for oxygen, SATs monitoring, OBS throughout. We use a combination of fentanyl and midazolam that we titrate to effect. And this is a picture of our procedure room in at Genea with the examination bed, the ultrasound beside, and then on the opposite end of the room, which I think is the coolest part of the egg collection, is this where the scientist is at their incubator and microscope. And in real time, they're looking at the follicular fluid that we're aspirating off and looking for the number of eggs. So by the time the procedure's finished, most patients know how many eggs we retrieved. They don't yet know how many of those eggs were mature and suitable for freezing down. The oocyte is the biggest cell in the human body, but when we collect it, it's surrounded also by this sort of fluffy cumulus cell layer, which is designed to sort of nourish and protect the egg as it develops. Unfortunately, not every follicle has an egg, and not every egg that we collect ends up being mature enough to be fertilized for an IVF cycle or to tolerate being frozen down for fertility preservation. In terms of frequently asked questions, the first one I get from patients and clinicians is, what test do you need before an egg freeze cycle? And the answer to that really is there are two main ones, and they're all about ovarian reserve, the AMH and the antral follicle count. We can see patients and do all of those tests after they've arrived, but if they already have them, it cuts down the number of appointments they have to have with us, and hence the expense of appointments. We always counsel patients who are thinking about a pregnancy or a family at any point about genetic carrier screening. So if you've already counselled them and they think they'd want to go with the standard 3-panel gene test, then it's also helpful if that's been ordered as well. The AMH is, it's in our reproductive years expressed in the follicles. They're very low in females pre-pubertally, and then they start to increase at puberty. We don't really know, we don't have good data about what normal AMH levels should be in that sort of 10 to 16-year age group. We're pretty good at knowing what it should be from the age of 20 onwards. It's not a perfect test. What it tells us when it's in the normal range is that that person is likely to reach menopause at an average time based on community rates. So for us in Australia, it would be an age of 50 to 52. Very high levels can indicate polycystic ovarian syndrome rather than excellent fertility. And it's now included in most of the recent PCOS updates, not as a diagnostic test by itself, but as an adjuvant test when you're looking at diagnosis. However, I think it's important to know that a young woman with a low AMH is still more likely to fall pregnant than a woman over 40 with a very normal AMH because of that age and egg quality thing that comes into it. The AMH doesn't tell us anything about the quality of the eggs. For us as fertility specialists, the AMH is really important for different reasons. It has to do with the cycle. We use it as part of the information to dose the FSH that we use for a stimulation cycle. And it also gives us a hint as to which women are more likely to be at risk of ovarian hyperstimulation syndrome, so we can watch them much more closely. AMH is only one way to monitor ovarian reserve, and thankfully we've got another test we can do to add into it, and that's the antral follicle count. It requires an experienced sonographer to look at and count the number of follicles in each ovary that are greater than 2 millimetres early on in the menstrual cycle. The perfect time is around day 3, but sort of anywhere from day 2 to 10 is good for an antral follicle count. We know it can be impacted by the pill or other hormonal medications that suppress ovulation. And we know that with polycystic ovarian syndrome, the ovarian morphology is polycystic, so the antral follicle count is likely to be incredibly high. And again, this doesn't tell us anything about the quality of the eggs. What it does give us a really good guide to is if we did really well and successfully stimulated them in an ovarian stimulation cycle, we've got a bit of a predictor of how many eggs we could expect to get. In terms of age-based averages, if you're 25 to 34, the average number of follicles on an antral follicle count sits at about 15, with quite a wide range either side of that. At 35 to 40, that drops to about 9, and 41 to 46, it sits at about 4. This is a big question that everybody asks, and I find it incredibly difficult. There's really no magic number to aim for when we're freezing, and all of the data that we've got to try and inform this question and answer, and the matrices that are being developed to try and work this out for patients are all developed from IVF cycles, not egg freeze cycles. And we don't have good numbers of people who've come back to thaw and use frozen eggs, because the number that are doing that at the moment sits at about 10%. So 90% of people who have social egg freezing don't ever come back to use those eggs. The numbers that we use are always individualized, and we use age, weight, AMH, and antral follicle count to give them a bit of a guide for what they could expect. But if you look at sort of on average around the age of 35, aiming for 15 to 25 eggs seems to be a good number to aim for. When you look at a standard egg freeze cycle, the average number of eggs we get sits between 5 and 15. So some people will need more than one, sometimes more than 2 cycles to achieve those numbers. And for some people, the reality is that no matter how many cycles we do, we will never get close to that number of eggs. So it's a very individualized discussion. For some people, though, they want to have the discussion, gain the information, and they'll say, I'll do this once, and whatever number I get is fine with me, which I also think is excellent, rather than aiming for a specific number, which sometimes can be really difficult to achieve. And the reason we need so many eggs is that there are a heap of steps to go through between egg collection to transferring an embryo and freezing down embryos that are left over. Of the eggs that we collect, not all of them are mature. We usually lose 2 or 3 that aren't mature enough to be frozen down or fertilized. Of the eggs that we do fertilize, not all of, or that we try to fertilize, not all of them do fertilize. Not all of them make it through to the day 3 check, and not all of them make it through to that blastocyst stage where there are 2 distinctly different cell groups developing. When we transfer an embryo, not all of those embryos result in a pregnancy, and we don't always have a large number left over to freeze down. So we tell patients that a successful IVF cycle results in 1 healthy embryo to transfer, which is, I think patients hope, and it would be very nice if we could just do this once and have a whole heap left over, and that certainly does happen for some people, but not everybody. We've spoken about this a little bit, about what age is best, and that's really based on what we know about egg quality and how that declines with age, and the evidence that's slowly emerging about successful pregnancies after an egg collection with those eggs thawed and used for embryos. We still say that the ideal age is at or just before 35, but there's still good evidence that cycles after that can be successful and cost effective. So I think everyone deserves a chance to have a discussion about it if they're still in their fertile years. And again, as I said before, we're balancing that against doing this too often in young people who are never going to come back and use those eggs, against getting that fertility window and giving them the best shot at a pregnancy later. And it's a hard and imperfect discussion. This is a bit of information on how much an egg cycle costs. This differs a little bit between different fertility centres, and there are other options in Sydney that are lower cost. There's public hospitals in Sydney who do medical egg freezing cycles for our cancer patients. This is only referring to a social egg freeze. For medical egg freezers at Genea, the procedure and all of the Janaea components are completely bulk billed, so there's no out-of-pocket costs for the patient except for the costs associated with Lingard Hospital, because we haven't had control over their billing. So if a patient who's having a medical egg freeze has health insurance, it's the excess on the health insurance. For those that don't, the out-of-pocket expense for a medical egg freeze is about $2,000. For a social egg freeze, you're not eligible to claim a Medicare rebate. Janaea fixed this cost and didn't increase it with price changes recently because they're aware patients aren't entitled to a Medicare rebate. So the out-of-pocket expense for the cycle is just shy of $5,200. But there are some extra bits on top of that, like the hospital admission costs and the medication costs, which are about $1,500, and the storage each year, which is $600 per year. The short answer to this question about how long eggs or sperm or embryos can be frozen for is really as long as you need them to be. Different clinics around Australia have a different length of time, and it's outlined on the consent form when you undergo your treatment. In Newcastle, our standard period of freezing is 10 years. In Sydney, it's 15. But you can extend that storage time when you're signing consent and adjust your contract, or when it's closer to the 10 years, you can push that out and extend it for a much longer period of time if you're still needing the eggs to be frozen. This is a new question for us. We're usually seeing patients who've been off contraception for years and who've been trying to fall pregnant but haven't been successful, and we've not had to think about it before. But with the increasing numbers of social egg freeze patients, they're often on contraception because they're not ready to have a family. So we're getting better at this. They can definitely stay on their pill up until and beyond a little bit their consultation with us. We stop it just before their egg freeze stimulation cycle starts, and the withdrawal bleed after stopping the pill actually helps us time the cycle. So selfishly, being on the pill is great for us because we can control and time everything. The Mirena is completely fine. Mirena can stay in during the whole process and the egg collection. We occasionally exchange Mirenas at the time of egg collection, so it's not a problem at all. Depo and Implanon is slightly more complicated because they're so suppressing. We usually recommend removal of the Implanon prior to starting or delaying the next injection of Depo. Ideally, we'd love to have a withdrawal bleed before we start the cycle, because then we know that the ovaries are at baseline and that they're sort of outside now of that suppressive effect and will respond quite well to the stimulation. Theoretically, though, we can leave them and we can use slightly different medications at different doses. We just anticipate that the cycle is going to take longer and recruiting of the follicles will be slower. Just a short little bit now on embryo freezing. We do offer this in the context of medical fertility preservation for patients who are in well-established relationships where the partner has sperm, because embryos freeze so much better than eggs. They're a smaller cell, they're not as likely to be damaged by that vitrification and thaw process, and they've already managed to go through so many of those steps where we lose eggs. So they were already an egg that was successfully retrieved, they're already an egg that was mature enough, it's already fertilized, it's made it through day 3, it's made it through day 5, and we've got a healthy blastocyst that's been suitable for freezing down. So we do have a higher pregnancy rate using embryos compared to eggs. The potential negative, I think, that needs to be considered is that when you freeze an embryo, you are locking your genetic material in with that person. And as difficult as it is to talk about it in the moment, things happen, we all know, with relationships down the track, and both parties need to be consenting to use of those embryos at the point when they're being used. So I do have difficult conversations with people about whether they really want an embryo or whether they'd like to just freeze their genetic material down. I'm not going to spend a lot of time talking about sperm freeze because I'm sure a lot of you are familiar with it and probably order it on your semen analysis on your patients a lot. But obviously, if the gonads involved and are at risk of being damaged by chemotherapy or radiotherapy or gender affirming hormone treatment, then a sperm freeze is the best way to preserve fertility. And an ejaculate sample is always the best because they're mature sperm. So the difficulty lies with people who aren't at a Tanner stage where their genitals are developed enough to be able to reliably get mature sperm from an ejaculate. When you're telling patients how to optimize a sample, it's best if they have a regular ejaculation at least every second day leading up to their sample, and then they have a break with abstinence for 3 to 5 days prior to the day that they provide the sample. The sample needs to be booked in, and they can provide the sample on site or at home, and just they need to be within 1 hour of the collection centre. So as long as it's kept sort of body temperature and not popped in the fridge or left on the dashboard in the sun, and it needs to be them that deliver their sperm. They can't have a partner bring it in or a friend bring it in. In terms of costs for a sperm freeze, much more economical than an egg freeze. The storage costs each year are exactly the same, but the cost for the sperm freeze is $300, and that includes the initial semen analysis, then the freeze down into straws. One of those straws is then thawed, and a post-thaw analysis is done by the scientists to make sure that that sperm copes really well with that freeze-thaw process. The last bit of fertility preservation I will spend time talking about tonight is ovarian tissue harvest. And this is the one that I'm involved with quite a bit because of the pediatric adolescent side of things. So this is really useful if there's not enough time to do an IVF cycle. We realistically need 2, sometimes 3 weeks to run a cycle, depending on where they are in their menstrual cycle. And if we don't have that time and they need to start treatment straight away, a tissue harvest is a much better option. It's also a better option for those younger patients with ovaries who just, it's inappropriate to put them through the monitoring and the collection of eggs from an ovary. Or if those procedures like transvaginal ultrasound scans and transvaginal collection will trigger dysphoria. The other thing to note is that we can't use this yet for blood-borne malignancies. So lymphoma and leukemia patients can still have this treatment, but at the moment we're storing it in the hope that one day we'll be able to reimplant the tissue, but now we're not. The reason for that is that there's a risk of reintroducing the malignancy to the patient when we put it back at the ovary. We try to collect at the time when tumour load is reduced. So this is the one time we don't collect before treatment starts. We tend to collect it at a break in treatment. This is a picture taken from the laparoscopic procedure that we use to collect the ovarian tissue. We use scissors and no electrical current until after the tissue's been removed, and then we use electrical current just to seal off the blood vessels from the ovary that's left. We remove the surface of about a half or sometimes a third, depending on how big the ovary is. We used to always take an entire ovary, but we've moved away from that, which is good. And then that tissue is removed and taken via a courier. For us in Newcastle, it's taken to Melbourne, where the team of scientists spend hours processing the tissue. I'm told it's about an 8-hour job to get the tissue ready for freezing down. It's broken up into strips before the vitrification process. When it comes time to using that tissue down the track, a couple of the strips are thawed and then they're re-implanted into the ovary and end up taking a bit like a skin graft. It's the coolest thing. And you get restoration of hormonal function as well as the production of maturing eggs. For some people, there have been natural pregnancies using this, but a lot of people having tissue reimplanted still need to go through an IVF style ovarian stimulation process in order to stimulate. The little strips of tissue that are reimplanted do have a life. They tend to last for about 5 years, and then that hormonal and ovulatory function drops right off, which is why we try to collect as much as possible so then new strips can be placed if we're needing them. And there are two reasons to put the tissue back. One is to gain the fertility function back, but it's also being used to regain the hormonal function so that patients aren't committed to taking exogenous hormonal treatment, which isn't quite as good as endogenous hormones in terms of cardiovascular, bone and brain protection. The cost up front is less, which is appealing to patients, but I think it's really only deferring that cost to later. We perform the procedure, the surgical procedure for retrieving the tissue in the public hospitals at no cost to the patient. The courier fees and storage fees and processing at the lab are mostly covered by fantastic pots of money from charities. So there's a wonderful foundation, Sony Foundation, that covers anyone having treatment that will render them infertile or have a high chance of rendering them infertile if they're between the ages of 15 and 30, and they will cover the procedures and the transport and all the storage. The Children's Hospital in John Hunter will cover the cost as well for kids who have to undergo this treatment who fall outside of that 15-year age range. But for other patients, the courier cost is about $1,800 up front. The storage fees are very similar for storage of anything else. And then there are the costs later on of having the tissue reimplanted, stimulated, having the eggs collected and the embryos retransferred. The outcomes are awesome. In 2020, I think Melbourne were a big team who've got a lot of experience with this. They had research on 55 grafts. They had 39 embryos transferred, and they had a clinical pregnancy rate of 25.6%, which was amazing, and a live birth rate of 18%. So when I started counselling about this in 2016, it was very much under an experimental umbrella, and that was the advice we were giving to patients. But now there's been over 200 babies born worldwide, and 2 of those babies were born to people where the tissue was collected before menarche. However, they were perimenarchal, so the ovaries had likely been switched on a little bit and had a hormonal function and had matured a bit already. The numbers we're waiting to see jump up are the ones from girls where we collect the tissue when they're very much pre-pubertal. And finally, a quick note on Zoladex before I move on to touch on gender diversity. Zoladex is a GnRH agonist, and it's really an adjunct to the other treatment. It isn't the best at fertility preservation, but it's a low risk option that can be introduced very quickly, has a very well tolerated side effect profile in the context of the other treatments they're having, and the benefit of a high likelihood of causing amenorrhea when they're going through chemotherapy treatments that are likely to tank their blood counts. The evidence is a little bit haphazard. The RCTs that have been done range from 0 effect to a 40% improvement in ovarian function. So it's hard to give exact numbers and counsel. There was a Cochrane review that collated everything back in 2019, and it included about 1,300 women, and they found it to be successful in terms of return of ovulation and preventing early menopause, but they didn't look at live birth rates. So I tend to recommend it because I think it's a low risk option that has a chance at success, but I'm very cautious with the way that I counsel and tell them that really the jury's out in terms of evidence, and I can't guarantee them that it's going to work. Gender diversity is a complex area. The evidence is slowly evolving, but we're counselling without a lot of evidence to support a discussion either way. And the really dicey area that I find the most challenging is for young people who have received puberty blockers from a very early stage of pubertal development, who then go on to cross hormones, and we just don't have the evidence yet about how their gonads will perform if we were to lift that cross hormone away and allow some recovery and progression through the puberty that gonad would have gone through. We know that estrogen impairs sperm function and spermatogenesis while people are on it, We know that it causes testicular atrophy. And the best time to get healthy, mature sperm is once the young person has reached Tanner 3 to 5, ideally beyond about 4. But that's the Tanner staging where the irreversible changes like voice deepening and Adam's apple start to come into play. And it's exactly what the young person is trying to avoid. Testosterone's a slightly different story. In that we know now that this is a space where evidence is really exciting and is coming out quickly. Pregnancies are definitely possible after stopping testosterone. We don't really know whether testosterone, when it's been taken from a very early age and taken for years and years and years, has an impact, but those are the patients who haven't wanted to stop testosterone, so it hasn't really been tested. It can, with long-term use, lead to a polycystic morphology of the ovary, and sometimes that's reversible, sometimes not. And it should be noted, just while I'm on this, that testosterone isn't a contraceptive, so people who are having penetrative intercourse with someone with a penis need to be on contraception as well. So puberty blockers definitely don't cause infertility. We know that estrogen impairs sperm function, so it's good to offer a sperm freeze before they start, if that's what they would like to do. And there's new evidence in small numbers of patients that lifting the estrogen therapy leads to functioning, good quality semen analysis after they've stopped, from anywhere from a few months to a couple of years, and some people just take a little bit longer, but the evidence is really promising. There's definitely pregnancy after ceasing testosterone. There's great results coming out of Boston, who have huge numbers at Boston IVF, and they've published on that from 2019, where they demonstrated that cisgendered people undergoing IVF treatment had the same rates of egg numbers collected and embryos made as the gender diverse people who had been on long-term testosterone. So that was great. And now where there's emerging evidence for people who've continued on testosterone and have undergone stimulation cycles and have successfully collected good quality eggs and made good quality embryos without having to stop their testosterone. Clearly, those embryos were implanted into a surrogate or a partner, not the person on testosterone. I think one of the important take-home messages from all of this, though, is that the decision about whether to freeze eggs in a medical or a surgical setting, or a social setting, or freeze tissue, or go on GnRH, or in a gender space, it's not the decision about whether doing it or not doing it. There's no right answer. It's having the chance to sit down and have a conversation and be well informed. That's the important bit. There's people who've spent a lot of time looking at this in oncology patients and looking at decision regret. And the overarching theme was that when they were not given the opportunity to have a conversation, they felt regret. They didn't feel regret from deciding to undergo fertility preservation or not undergo fertility preservation, which I found really interesting. My final slide for tonight is about IVF success, comparing the different clinics, but also personal IVF success predictors. And it's a really great resource for you to give to patients to look at, and also to look at yourself if you're interested. It's government funded, and it uses all the ANZAR data from most of the clinics who are involved in IVF within Australia, and you can look up the success rates of each clinic and compare them. But the one that's cool for patients is that there's a personal IVF success predictor where they enter in a few characteristics and whether or not they've had babies before, whether this is their first IVF cycle, how old they are, and if they know of any infertility issues, and it can give them a chance of successful pregnancy. So it's nice for patients to have that going into their fertility consultation. And that's all I've got from a prepared talk point of view, but I wanted to stop now and open it up to you guys so that I can run through any questions that you wanted me to cover tonight.
We have had one question come through. Is AMH useful after 43 years? old. Based on the graph that cuts out at this age, are we missing good data or is it not useful?
Yeah, it's a good question. I don't think we have the same numbers of data that we would in younger people because we order it a lot less. But I think it becomes a bit less important because regardless of the AMH level, the success rates of IVF treatment after 43 are vanishingly small. So still possible, and certainly we know that spontaneous pregnancies are still possible, but it's very small.
That's the only question that's come through. Thank you everybody for attending. And Angela, if there's nothing else that you wanted to cover, we might finish for the evening.
Thank you
Thanks,
so much
everybody.
for having me.
Oh, you're so welcome. And we will put a copy of the webinar along with a PDF copy of the slides in the education library on the website. Thank you so much, everyone. Good night.